Доброго вечора, українські радіаційні онкологи, медичні фізики та радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro APM experts for Ukraine. Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, RIS Contra Cancer, with Sweet Care Support. We are all excited to present the 10th lecture in the course. And the topic today is kidney SBRT, and we have two amazing speakers from MD Anderson Cancer Center, Dr. Chad Tang and Eun Yong Han. Dr. Tang is a radiation oncologist at MD Anderson Cancer Center, associate professor in the Department of Genitourinary Radiation Oncology. He has joined appointments in the Department of Investigational Cancer Therapeutic and Translational Molecular Pathology. He received his MD from Stanford and completed residency at MD Anderson Cancer Center. His research and clinical practice focus on treatment of advanced prostate and renal cell carcinomas, with emphasis on oligomets, oligoprogressive patients. He has completed and continues to run several investigator-initiated clinical trials investigating these diseases and with the emphasis on translational correlatives. Welcome, Dr. Tang. Thank you so much for preparing the lecture today. And our second speaker is Dr. Han. She is a medical physicist at MD Anderson Cancer Center, associate professor in the Department of Genitourinary Gynecology Radiation Physics. She received her PhD from University of Florida and completed her medical physics residency at University of Minnesota. Her research focuses on adaptive radiotherapy and global oncology. Dr. Han has served as principal investigator on several internally funded grants and clinical trials, and she currently serves as the chair of a subcommittee on the APM International Council. Welcome, Dr. Han. Thank you so much for preparing this lecture today. So it's an honor for us to have you both here. Thank you so much for preparing this topic, and we are eager to learn about kidney SBRT. The podium is yours, Dr. Tang. I'll stop sharing.
Great, thank you. Okay, can everybody see my slides?
Yes.
Okay, wonderful. Thank you for the opportunity to talk today, and hope everything is going well this evening back in Ukraine. So I'm here to talk about renal cell carcinoma, and I preface this as a cancer that radiation oncology forgot, but I think we're remembering it again as we're seeing more and more data in this area, and I think it's a very exciting field. So with regards to the prevalence of kidney cancer, unfortunately, I don't have the statistics for Ukraine, but in US, it's actually a very common cancer. It's a top number 6 cancer for men and number 8, 9 for women. And if you add the numbers together, it ends up being 80 to 90,000 patients per year. And that's about the same as gynecologic malignancies, if you add those together, uterine, ovarian, et cetera. So it's a very prevalent cancer. And over time, and this may be due to increased CT imaging or perhaps carcinogens in the air and the water, but there is more kidney cancer being detected. So as we look over time, we're probably going to see this incidence only increase with time. Now, the kidney doing SBRT here is actually a very heterogeneous area. So you have 2 kidneys, obviously, and they situate differently. On the right side, you are dealing with the duodenum, you're dealing with the colon, you're dealing with the liver. On the left side, you're dealing with the stomach, you're dealing with the last part of the duodenum, the small bowel. And then we have tumors in the superior portion, as you can see, that would be abutting the stomach, and tumors in the inferior portion that would be abutting the colon, and vice versa. So the area and the organs that you have to look at for SBRT to the kidney can be highly variable, because there's just such a vast area that these cancers can occur. So a quick word on staging. Kidney cancers can become quite large since this is the retroperitoneal space is not really innervated by much, so they can get quite large before you have symptoms like bleeding or anything else. This is just a reference for the different staging here. You can see T2B, for instance, greater than 10 centimeters, which is quite massive in the kidney. In addition, kidney cancer is it's not just one disease. It's actually a spectrum of different histologies. So the most common type of kidney cancer is your clear cell renal cell carcinoma, which accounts for 75% of all renal cell carcinomas. There are specific alterations associated. VHL is generally universally altered in all these patients, but there's other alterations as well. And in addition, the second most common is papillary, which behaves relatively similar to clear cell. But then what behaves differently from clear cell are cancers like chromophobe, which ends up not being very responsive to systemic therapies. And then on the other end, we have some very rare cancers. One which we do a lot of is renal medullary, for example, which only occurs in patients with sickle cell disease, sickle cell trait, because of constant sickling. And you use chemotherapy here, like gemcitabine, adriamycin, that kind of stuff to treat renal medullary. Well, for clear cell, you don't use any chemotherapy, using targeted agents like TKIs and IO therapies. Very broad spectrum diseases are accompanied in renal cell carcinoma. Not to mention, in the kidney, you're also going to have lymphomas, upper tract urinary carcinomas, those kind of things as well. So a wide spectrum of disease here. So I'm going to first start talking off about radiation and folklore in this space, then talk about early stage cancer and the data for that, then oligometastatic and oligoprogression in that order. So why do we think of kidney cancer as being one of the most radiation-resistant diseases? And as far as I can tell, going back, it was this one meta-analysis done by de Chevigny in Red Journal in 1996. And what he did was he looked at a bunch of different papers that are published in radiation literature looking at various cell lines. And they all had a couple of different parameters they looked at. One was the amount of cancer surviving after 1-2 grade fraction. And what he found was like 5 cell lines papers talking about lung cancer and maybe a couple on prostate cancer, a number of breast cancer. There was only one renal cell carcinoma that was cell line that had radiation data. And it so happened that the number of surviving cells after 2 gray was very high. It was 81%. It was the worst among all different cancer types. When he ordered this list based on just how many cancer cells were surviving in a cell line after 2 gray, renal cell carcinoma ended up being the very bottom of the table. It was the worst, 81%. And that's where we come with radiation resistance. Now, if you look further at this renal cell carcinoma cell line, it is this one cell line called the ACHN cell line, which was derived by the paper Tang et al. In 1987. And this cell line was a cell line from a malignant pleural effusion of a 22-year-old patient with papillary renal cell carcinoma. A 22-year-old with kidney cancer, especially metastatic kidney cancer, is very rare. I wonder a little bit whether we're really dealing with sarcoma or something here because of the age. It's definitely not a clear cell. And the papillary is a bit of a catch-all term. So it could mean, so back in 1987, it could be a number of different histologies. So I'm not even sure what they radiated there, but that's where this data comes from, why we think radiation is very resistant. Now, in addition, around this time, there was a lot of interest using adjuvant radiation therapy for different diseases, bowel diseases, prostate, et cetera. And one area where there was some retrospective data was in kidney cancer. So there were a number of studies that were launched in the 1970s looking at adjuvant radiation therapy after nephrectomy for high-risk stage 2, 3 renal cell carcinomas. And they were all universally randomizing patients to adjuvant radiation therapy or observation afterwards. And what this one Denmark study showed was that adjuvant radiation made your survival actually a little bit worse. This was not significant because only 50 patients. In addition, 12 patients had significant radiation complications, including 5 patients which had a grade 5 toxicities. The patients died because of the radiation. This led a very dark mark on the investigation of radiation therapy for renal cell carcinoma. In fact, this study and these studies were some of the last randomized data coming out of renal cell carcinoma looking at radiation. Now, why was the radiation causing so many problems? And you can look at it one way. It was at the radiation fields, which was published by this Denmark study, but using 2D radiation, radiating about 2/3 of the abdomen with hot spots of 112%, probably even worse, depending on, the size of the patient. So you were radiating a lot of the patient, a lot of bowel, and there's no, no surprise that they're having a lot of side effects and even grade 5 side effects from doing this much radiation over this big of an area. Now, I don't need to tell this group, but the radiation has drastically improved since then, 1970s, 2D, which was what's used in the studies, 3D obviously is a big improvement, and then finally IMRT, VMAT. This is something just that we're playing around with, but this is like what we do for gating for our renal cell patients. What you can see here is a movie of a kidney, and the beam is only on when the kidney is inside the yellow PTV margin. So this is a 2 millimeter margin. I purposely made it very, very tight to spare the normal kidney. Right now, the patient's kind of breathing. You can see there's an orange trace, so the beam's not on. But once the patient settles into the breathing, as you're seeing right here, then the trace becomes clear. So I can see that right about now, and then the beam is on. So just a way that we're using to kind of help refine the dose even more and define the coverage even more. Okay, and this is how we do this. So what happens is the patient is actually seeing this screen and breathing, and whenever they want to do this, they are basically breathing their own kidney into their own PTV, and the MRI is taking 6 MRIs per second. So just a little bit of kind of a tool we're playing with. This is the Unity, obviously, and this is me and my kidney in there, so there's no HIPAA problems here. But something that we've been using to kind of reduce our margins. Okay. So all that folklore aside, there's a number of other studies done afterwards. This was actually a study done from Stanford where they looked at clonogenic killing at different doses. So the data I showed earlier was 2 gray per fraction. Now, 2 gray per fraction, the fraction of cells that remain in the ACHN cell line was 81%. And as you can see here, there's a shoulder of the curve that happens at about 2 gray. You're not killing too many of the cells. But this shoulder becomes more steep and more of a drop-off as you're getting more to 4 to 6 to 8 gray, suggesting that you're getting more logarithmic kill in these 2 renal cell lines, and you're getting to, especially when you get into SBRT doses, which is more here, 7, 8, 9, 10 gray. So you're going to get effective cell kill with SBRT doses in this. And this has been confirmed in animal studies with the high doses as well. So even though the ACHN cell line is, we're not actually sure what it is, low doses per fraction is probably not optimal for clear cell renal cell carcinoma, and you need more high doses per fraction, which we can achieve through SBRT. Okay. So moving on, let's talk about SBRT for early stage renal cell carcinoma. Here's a patient we treated back in September 2020 with about a 4-centimeter renal mass. We were doing an IMRT version here with a CT on rail, so that it's not as pretty as some of the plans we'll show you later. But we treated this patient 42 grade 3 fractions, very much similar to Fast Track 2, a study I'll talk about in a bit. And what happens after a couple of years is the size is just marginally smaller. And that's generally kind of what you'll see with renal cell SBRT. The size doesn't change a whole lot. It'll change marginally, or it won't grow. But the important thing is it won't grow, and that's what we're looking for after renal SBRT. Okay. So the best data here is our colleague Shankar Siva's study, where we looked at Fast Track 2. This was 70 patients across Australia, New Zealand, and I think there might have been one site in Europe. And patients had biopsy-proven kidney cancer and received SBRT for smaller tumors under 4 centimeter, and larger tumors got 3 fractions, 42 grade 3 fractions. Now, at follow-up, which was about 3.5 years, what they saw was 100% local control. Now, mind you, local control means lack of resist progression, and resist progression is 20% increase. So a stable lesion, which is what we see a lot of times, will be considered local control. Freedom from distant metastatic failure was also quite favorable here. And what we saw here was only 3 distant failures over time. Cancer-specific survival was also excellent. There was no kidney cancer-related deaths. Toxicity is worth noting to be quite well tolerated. The side effects were 10% grade 3, and most of these resolved after some time. A lot of this was you can see, flank pain or diarrhea, nausea. This resolved for many of these patients. And kidney function is something that's worth noting. So these were mostly patients with 2 kidneys, and they had a median baseline GFR of 61. And this decreased by about 14.6 at 2 years. And at 2 years, it kind of levels off. So it doesn't really decrease that much further. And what I like to tell patients is that we'll generally we could lose about a quarter of your kidney function at 2 years. Not everybody can come with a baseline GFR of 60. If somebody's coming in with a baseline GFR of 30, you're probably not losing 15 points. You're probably going to lose a quarter of that. So you're probably losing about 7 points or so. In addition to this excellent efficacy study that was published in Lancet Oncology, there was also a follow-up study published in Red Journal, which looked at kidney function. Now, what I want to show here is the different doses at baseline and 12-month follow-up. You can see here that this dotted green line is 100%. And we generally see with a 100% dose is that you have pretty much all loss of total kidney function in those glomeruli around that area. And what we see with 50% dose is you have some substantial loss, but not 100% loss with 50% dose. And they were doing SPECT imaging afterwards, and you can kind of see this trend where about 100 BED, you start losing pretty much all the function in those glomeruli. It doesn't get much worse after 100 BED. And this ends up being about 25, mid-20s gray when you're doing 3-fraction SBRT. So I constrain my 25 gray, and I constrain my 10 gray. But after those high doses, you're probably not losing too much more. Now, how good is renal cell carcinoma compared to other techniques? This was a nice study done looking at interventional radiology, which is usually what we're looking at for smaller tumors. This was a meta-analysis with 612 patients receiving SBRT, 7,000 patients receiving various forms of IR interventions from RFA to cryoablation. What we see here, local tumor control-wise, is that among the patients receiving SBRT, the local tumor control is excellent at 5 years, 95%, very much in line with Fast Track 2, and not terribly different than what we see for the IR techniques. Now, where radiation shines a little bit more is that the control rates when your tumor size is larger, greater than 4 centimeters, it still remains very good, 92%. And this falls off dramatically with IR techniques. Cancer-specific survival was also excellent regardless of what you do. A lot of these kidney cancers that we're treating are not going to, in 5 years, lead to patient's death from the localized setting. And then toxicities comparing SBRT versus other different modalities show, once again, that about a 10-point loss in GFR from about a 50 to 60 baseline GFR, so about a quarter again. And this is not terribly different than RFA or cryoablation. The grade 3 to 4 adverse events were also quite modest, 2% for SBRT, not that different for cryo, RFA, microwave. So comparable, where radiation has advantage is greater than 4 centimeters. Now, I always think of SBRT for renal cell carcinoma as where we were with SBRT for stage 1 lung cancer about 10, 20 years ago. But despite the fact that we're using it for older, more frail patients with larger tumors in unfavorable location, we find that radiation for RCC is more effective with higher dose per fraction SBRT. Radiation is safe. If you look at the larger studies, 600 plus patients, 2% or less grade 3 or higher toxicities, it is associated with a modest GFR decrease, and this depends on how much GFR you had at the beginning. So I usually quote about a quarter of the kidney function is going to be lost at maybe 2 to 3 years. And it is associated with excellent oncologic control. No matter what series you look at, you're looking at greater than 90%. But oncologic control is RECIST-based, the lack of RECIST-based progression. So, your urologist or your IR doc will say, well, it looks the same at 6 months, and you should be saying, well, that's what it's supposed to look like at 6 months. So keep that in mind as a caveat. Now, radiation for oligometastatic cancers, moving on to a little bit more advanced. I like to bring up this old paper from 1938. This was a paper describing a patient with a kidney cancer and a metastasis that both were removed with nephrectomy and subtotal lobectomy. And what the patient saw after 5 years was no evidence of disease, and this was reported out in 1938. So the treatment happened in 1933. This was before we even had the word oligomet in our dictionary, I think. So this was preceded all systemic therapy. In 2024, and once again in 2025, 2026, hasn't changed much. These are the current NCCN guidelines for metastatic RCC. It includes clinical trial, first-line systemic therapy, mastectomy or SBRT for oligometastatic disease, mastectomy followed by adjuvant pembro for a year, and best supportive care. Now, this is a very wide open menu of options without much differentiation. And between clinical trials and best supportive care is pretty much anything you can possibly think of to treat this patient. So not much guidance here. Now, there is generally a consideration that even when a patient has become metastatic for renal cell carcinoma, there are patients who have indolent metastatic disease. And one of the first studies to investigate this was done by Brian Reaney back when he was at Cleveland Clinic. He enrolled 48 patients who were systemic therapy naive and asked if you didn't do anything, just follow them with surveillance, no systemic therapy, how long until you need to start systemic therapy. After a median follow-up of 38 months, these were the results. So the time on surveillance was 15 months. So patients could be watched without evidence of harm for more than a year. The PFS was 9 months, and overall survival was very good as well. You can see the median was just reached about 3 years or so, a little bit more than 3 years. If you look at the swimmer's plot, you can see that there are a number of these little green dots. Now, what are these little green dots? They are local therapy resections for metastatic disease. I think most of them were resections, and one of them was SBRT or radiation. There was also possibility of doing local therapy and then putting them on surveillance, so local therapy before enrolling in the trial. I've asked Brian how many patients are in this camp. He really doesn't know, but it's a very common scenario to do mastectomy followed by surveillance afterwards. So I anticipate there are a number of those patients. So this is great. They didn't report toxicities, but on surveillance, there really aren't any. I want to contrast this to what we're doing in frontline renal cell carcinoma with systemic therapy. This is a big Checkmate 214 study. A number of New England papers came out of this. This is looking at sunitinib versus nivo-ipi, followed by nivo. Sorry, it should be nivo. For intermediate poor risk IMDC renal cell carcinoma. What I want to point out is the side effects. So when you're having nivo-ipi, which is one of the more benign combinations, one of the less toxic ones, although you can have some very bad grade 3, grade 4, and grade 5 toxicities. The grade 3 or 4 toxicities was 45%, much higher than what you expect with SBRT. When you add a TKI like sunitinib, and there are TKI combinations, it ends up bumping up to 60+%. In addition, progression-free survival, which was pretty good, is not forever. You can see with nivo-ipi, it's only 12 months. So just a kind of a baseline how you're doing with the best doublets that we have. So based on Brian Reaney's study and other studies like that, we enrolled this feasibility study. At this point, we didn't know if radiation would be feasible for these patients. So we did a study where we took oligometastatic renal cell carcinoma. They were all clear cell. They had to have up to 5 sites of metastatic disease. And and they were either had no systemic therapy, which is the majority of patients, or off it for at least a month. And then we did radiation to all the sites. We followed them afterwards, and if at progression, there was noted to be oligoprogression, meaning up to 3 sites of progressing disease, then we went back around in circle again and did more SBRT and on, until we found that there was more sites of progression. Then we started systemic therapy to all sites of disease. So we did this feasibility study first and published in 2021, and we saw that it was quite feasible, that we could do multiple rounds, and usually ends up being 1 round per about a year or so of surveillance. And after a median follow-up, about 1.5 years, we had a progression-free survival of 22.7 months, and systemic therapy survival not reached. The grade 3 to 4 toxicities was 10%. All these were reversible. There were some pain and myositis in the radiation sites, and then 1 episode of hyperglycemia from diabetes from a pancreas SBRT. So in addition to our study on the right, Rakib Hanan, about a year later, published another study looking at 23 patients who were systemic therapy naive. The 1-year PFS was good, 83%, and the 1-year systemic therapy survival was very good as well, 90%, very comparable to our study. Grade 3 higher toxicities was 4%. Now, after we enrolled this feasibility cohort, we saw that we were getting a lot of patients who fit this category being sent to us for SBRT. It took us 2 months to enroll the first patient, another 2 months to enroll the second patient, and then we were starting getting, at the end of this, 4 or 5 every month for radiation alone, no systemic therapy. So we then decided to open up, and this is also right around COVID time, an expansion cohort, which we published 2 weeks ago. So this is our expansion cohort of 120 patients treated with this approach. All of them clear cell, all of them with up to 5 sites of disease. Now, we know from the earlier study from Brian Reaney that the median time to systemic therapy initiation with surveillance alone was 14.9 months, and the 95% confidence interval was 10.6 to 25 months. We set 24 months systemic therapy-free survival as the threshold for success. So we said this would be a successful study if we hit at least 24 months. And after a median follow-up of 3 years, what we saw was that a median systemic therapy-free survival was about 3 years, 34 months. So this was way better than 24 months we initially hypothesized we wanted to beat for this to be an interesting option. And the overall survival was 87% at 3 years. I want to give you a little bit of reference. If you look at Fast Track 2, the overall survival at 3 years was 86%, and that's in localized kidney cancer. So the amount of, I don't think we're compromising patients' outcomes at all. As you saw from Checkmate 214, the 3-year overall survival was way lower. So excellent overall survival, systemic therapy-free survival was 34 months, and we had a 7% rate of grade 3 toxicity. So very modest, much better than 46% that you would expect with a nivo-ipi combination. We're always looking to try to select these patients better, and although this is not radiation, we did utilize a circulating tumor DNA assay through Myriad Genetics. To do this, we did a whole genome sequencing of our kidney cancer primaries. We developed panels, about 1,000, 2,000 candidate sites, and then we used that to look at the STREC2 plasma collected at baseline at 3-month follow-up. And what we saw was that in these patients who were generally considered low shedding patients, low volume, low shedding, 60% were MRD positive. And at 3 months, about a quarter of those patients with paired MRD, a baseline at 3 months, they converted to MRD negative. And as you can see here, those patients who are MRD negative at 3 months, the majority of them had more than 2 years of systemic therapy-free survival, while those with MRD positive did not. If you look at this, the Kaplan-Meier curve, you can see the MRD status at baseline or at 3 months. They're both very prognostic for systemic therapy-free survival, especially at 3 months. And this is what we expect to see a lot of times in bladder and other cancers, where after local therapy, the MRD status is going to be really prognostic. This looks like I've lost some formatting here. But I wanted to talk about a quick case here. This was a patient we treated back in 2021 We were found to have one lesion that was growing. There was a number of lesions up to more than 10. And we SBRT'd one lesion here, the SBRT plan on breath hold in the back of the lung. We watched further in January 2022. There's slow growth of actually just one lesion. These others we watched for a little bit. We generally do the 1 centimeter threshold for when we do SBRT, so this right lower lobe lesion. Then December 2022, another 2 lesions grew. We SBRT'd those as well. And then finally, in about 2024, we saw a new brain lesion, and we started this patient on systemic therapy. So we looked at this guy's ctDNA and another marker, KIM1, during the treatments. As we saw was after every round of SBRT, we induced them back into MRD negative status. So the MRD would be positive, we do radiation and go negative. Positive, radiation becomes negative. Positive, radiation becomes negative. And finally, when we decided that we should do the systemic therapy, what we saw that was quite high in the amount of ctDNA, 246 parts per million, much higher than we saw when the oligo met. And the KIM1, another marker, was also raised. Here's the trends of that patient over time. We're kind of showing up the years what we did. We had 3 rounds of radiation. Every time we saw the radiation, we went from MRD positive to negative. And then he started on nivo-ipi in February 2024, and remains on nivo-ipi today with stable disease. Had a good amount of time on nivo-ipi. And also had a good amount of time before needing to start systemic therapy, 33 months. Very similar to what we see in these patients. Now, what we're doing next, the next trial is looking at adding a little bit of pembrolizumab for a year afterwards on the Astros trial. This is a randomized trial doing radiation to all sites of disease, followed by pembro versus radiation, followed by observation. But that's not to say this arm, radiation plus all disease observation, is very good. And we have patients who don't really want to get the added toxicities of pembro and the added infusions of pembro. Okay. So radiation for oligoprogression. This is a patient we have with worsening renal function. He has a nivo after getting the nivo-ipi and had large hilar mediastinal lymph nodes. We radiate this. We generally do, we don't do SBRT for such an ultra-central lesion. We do 15 fractions. Here's 15 fractions of radiation. We did 52.5 for the GTV, 45 for the PTV. And then we follow up here decreasing disease, suggesting that we can continue the patient on the same line, nivo, for much longer. So what data do we have in oligoprogression setting? So there are 2 trials that are phase 2 single arm reported out. One is from Canada, and this was the Chung et al. Study, which looked at patients who are on monotherapy TKI. They had to have response, and they're radiated to the 1 to 5 progressing lesions. They wanted to accrue 62 patients, but only could accrue 38 because, number one, TKI monotherapy fell out of fashion, replaced with doublet therapy. That was the main reason. Another study by Rakib Anand, UC Southwestern, 20 patients with up to 3 sites progressing lesions. This was more liberal in what you could be on. Now, both studies showed that if you did radiation and kept them on the same line of systemic therapy, the time until new line of systemic therapy or death was about a year. So by radiating the progressing lesions, you could eke out another year on the same line of systemic therapy. Now, it's unclear based on these single-arm studies whether this is actually would have happened by itself if we just washed these spots. So we're doing the current Extend OP study, which is PI'd by Ethan Lundmere, looking at renal cell carcinoma, and we're randomizing patients to next line systemic therapy versus local consolidation to all progressive sites and continue on same line systemic therapy, followed by next line systemic therapy. So this will tell us whether the strategy of radiation and continue on same line systemic therapy here is going to be superior to just switching to next line systemic therapy. Bile duct nephrectomy. So kidney cancer is unique cancer. We're back in early 2000s. A number of urologists did 2 studies. One was the SWOG study. This study, they randomized metastatic renal cell carcinoma patients to nephrectomy followed by interferon alpha. This was back when only drug therapy was interferons. And this showed this showed an OS benefit. At the same time, the ERTC study did a similar randomization and also showed OS benefit. Keeping in mind this was only around when we had cytokines. The most recently, there has been data from the French group, from Carmena, which looked at nephrectomy followed by sunitinib. And this was still not modern drug therapy because sunitinib monotherapy is no longer used. It is much more modern than interferon therapy. And what this showed was that nephrectomy and sunitinib did not improve survival. So this whole world of side duct nephrectomy is up in the air at this point. We still do it in patients where they have good systemic control and the local disease is the only side of disease that's progressing, but it's used a lot less common. Now, this is an area where there's not much data at all. A number of ongoing randomized trials are currently accruing. That's the Nordic Sun study in Europe, the PROBE study, which is enrolling now, and this is in the SWOG group. SiloShrink finished enrolling at about 50-ish patients, and they should report out next year or so. This is SBRT to the primary in 30 to 40 grade 5 fractions with nivo-ipi. And then, of course, we have the Samurai study, which is enrolling patients who are getting doublet systemic therapy, SBRT to the primary, followed by standard of care immunotherapy versus standard of care immunotherapy. And this is supposed to, this is accrued about 70-ish patients, and I think we're going to the mid-200s for enrollment. So this will add potentially more data about whether radiation is going to be beneficial. So, in conclusion, for metastatic renal cell carcinoma, this represents an exciting new area of exploration for radiation. Radiation for oligometastatic disease could enable a long systemic therapy, free interval that is high quality of life, low in terms of financial toxicities and low in terms of toxicities. Because systemic therapies are expensive, they do yield some side effects, and by their very nature, they will eventually result in resistance due to just clonal selection eventually. Oligoprogression is an area where there's going to be some interesting, I think, data in the next couple of years. The single arm data does suggest that radiation to a single site of progressing disease can delay the time that you need to start the next drug by about a year. Now, whether that's just doing anything to change natural history or not, we're going to have to see when the phase 2 randomized trials read out. Finally, cytoreduction with nephrectomies is an open question at this point. It's being currently investigated with surgery, but also now with SBRT. And there's 2 smaller studies, one fully accrued and one accruing, that we are getting data in, I think, and we should have that data hopefully in the next couple of years. So I don't know what we should do next, but do I ask this question or?
Yeah, so you can read out the question and I will launch the poll.
Yep. All right. So hopefully I've been paying attention, but local control rates for SBRT for localized kidney cancer 5-year are approximately what percent? A, 90 to 50, B, 80 to 85, C, 70 to 75, or D, 60 to 65. Okay. And I see.
Yes, so we will wait until approximately 80% answers, and then I will end the poll and share results. So I'm ending the poll, sharing results. So majority answered B, 80 to 85%.
Okay. Well, I think it's probably more 90, 95% based on the data available, but it's not too far off. But thank you. Here's my contact information. If you have any questions about kidney cancer, and I'm on Twitter.
Oh, thank you so much. Thank you. And that's a very cute photo. That's your son?
Okay. Yep. No, it's a random kid I grabbed. No, kidding.
Oh,
Yeah, that was a couple of years ago. He's a little bigger now. Yeah.
Oh, that's good. But you can still lift him, huh?
Oh yeah. He's still not. He's like 6. So.
Awesome. Thank you so much for such a nice lecture. Are you able to stay till the end, or
Yeah,
you
I can
want
stay
us to
until
ask
probably a little after
questions?
1.
Okay. Okay, sounds good.
Yeah.
Thank you. Yeah, excellent. Great.
Can you guys hear me okay?
Yeah, we can hear you well.
Yeah. Hi, everyone. My name is
Hello.
Young. I'm honored to be here. I hope and pray the peace over the Ukraine, and I'll continue
Thank
to
you.
pray. And then,
Thank you so much.
let's moving on. Okay, so challenge. There are a couple of challenges specific for the kidney. I mean, it's applied to the lung or GI, but when we focus on kidney SBRT, the first of all, the intrafractional motion. It is caused. It is. Can you see my mouse?
Yeah, we can see your mouse. Yeah.
Okay. And then caused by the respiration and then GI organ motility, and then intrafractional motion can be mitigated by breath hold and then compression belt, and or free breathing gating, or using the larger margin from the 4D CT. And next, interfractional motion. This is caused by the stomach filling and bowel gas. A lot of time, the patient is instructed with the 3-hour NPO protocol, and then we provide the patient diet education and also anti-gas medication. And as we know, there are the poor visibility in CT near the target, either the cone beam CT, daily cone beam CT, that is caused by a strict artifact from the bowel gas. The mitigation for this is the imaging artifact during the daily IGRT, that we increase the margin or adjust the dose adjustment, or we don't, but other side they use a fiduciary marker. So question, which is the following is which is the following is not the common strategy for managing the motion in the kidney SBRT. A, 4D CT-based margin, and then B, abdominal compression, and C, breath hold technique, and D, stereotactic radiosurgery SRS boost.
So we'll wait until 80% answers. I see the answers are quite split. So let's see. Okay, I'm ending the poll and sharing results. So quite split answers. So 30% answered A, 30% answered C, 30% answered D.
I see. So maybe I didn't say clearly, but not the common strategy for the motion. The answer is the SRS boost. Okay, let's moving on. So the simulation, the usually patient, as you can see here, patient arms up on the half back block, and then we use a T-bar and then knee wedge, and also pneumatic the belt. And then a key point when we do the simulation for spine SBRT is whether we're going to treat the patient with the free breathing or a patient need breath hold. And also physicists who attend the sim supposed to generate the note. What most important thing in the note is what kind of a scan will be used for the planning, and also how many slides were used. Okay, just this is a brief overview. Can you see the slide? Okay.
Yeah, we can see it.
You see? Okay. So brief overview of our simulation process. So we start our mini scan to make the marked ISO, and then moving on to free breathing scan, the teeth to pelvic crest, and then start with the 4D CT, the crina to pelvic crest, and then if patient motion is less than 1 cm, we create the average and the mean for planning. And a plan is done on the average scan, and then contour for IGTV is done in the maximum intensity projection image. If a tumor motion is larger than 1 cm, we're moving on to breath hold scan. The patient should be able to hold their breath at least 15 to 20 seconds and within the 5 millimeter breathing window. And then we do the consecutivity at least 5 breath hold scan. And then the physicist select the most probable the scan, and then we communicate with the planning, the dosimetrist. And then if ideally tumor motion should be less than 5. If even with the breath hold scan, if tumor motion is not reduced to the less than 5 millimeter, we will consult with the doctor, and then the decision need to make whether we're gonna treat with the free breathing or compression belt. So during the 4D CT, we used the variant RPM system. I just want to mention that to capture entire range of breathing patient's breathing motion, we adjust the pitch. The pitch is basically how much the couch is moving in with the one rotation. So we observed before 4D CT, we observed what is the patient's breathing rate, constant breathing rate, and then we kind of customize the pitch to make sure the entire range of patient breathing motion is captured. Okay, just a brief kind of a recap of the compression belt. So this is we use Actina compression belt. It's designed to apply the pressure to restrict the patient's respiratory cycle motion, and then it has a medium, large, and then small size, and then it fit in the patient's ribcage through the iliac crest, and then we apply the pressure at the patient expiration stage of breathing, and then there is a potential the medical exclusion criteria for the compression belt. When patient has the aneurysm and then abdominal surgery and a gallstone and a hernia and severe COPD and dementia, it's not, we don't want to use the compression belt. And I just want to emphasize that when we use a compression belt, as you can see in the back, there is a specific kind of location. We kind of mark it, and also there's indication light is a market. So we try to do reproduce the setup as much as possible. Okay, and then this is a typical the planning. It looks like for the kidney, SBRT, and then especially the lesion was posteriorly located, so away from the GI tract. So again, the 42 gray in 3 fraction. So you can see the dose slope is a pretty very sharp, and the curve around try to save the normal the functioning kidney. However, if the lesion is superiorly located and also very close to the duodenum is one of the most critical, the OAR for the kidney SBRT. And in that case, after physician draw the IGTV, and it will be cropped by the GI tract PRB, which is 3 millimeter. And that will be our 42 gray, the target. And then we also, the PTV will be covered by 36 gray, and then the 5 millimeter margin will be added. And a lot of case that the GI tract, the duodenum is close by. We also add another PTV volume of the 6 millimeter margin, which is the 26. The 26, 36 is kind of 26. We use the Dmax for the duodenum, and then 36 is we use for the large bowel, the Dmax. So this is the organ at risk that we control. And then we use a partial the VMAT with the partial arc. Okay, let's just skip this one. So for the planning, the two physicists in MD Anderson, two physicists to check the plan, and also we utilized the checklist as you can see in this slide. And then also the SSD is provided, but if it's a breast hold case, the SSD should be provided on the breast hold while patient is a breast hold. We need to check while patient is on breast hold. We do the QA with the R-check. Okay, treatment delivery. We have the multiple different type of the treatment delivery. First is the CT on rail, and second is tubing with the hyperside, and then third, as Dr. Tang showed you, the MR Linac. Today I'm going to focus on the CT on rail and then hyperside. So just to high level, the brief summary. We align the patient with the final ISO. The align patient with the marked ISO and move to the final ISO. And then we do the quick MV image to make sure the patient is straight and the spine column is matched with the plan. And then we record the couch coordinate. And as you can see in this image, that we flip the patient, and we do the CT scan, and then flip the couch back and align the BB and make sure that we reproduce the recorded couch coordinate, and then we fuse the image with the CTOR and also planning, and then we apply the shift, and then we confirm those shift with the MB imaging, and we treat. I just want to show you that we have in-house the program to register the planning CT versus planning CT versus the CTOR, the CT. And then I wanted to show you there is no streak artifact from the vowel gas. So image is pretty clear. Yeah, let's move on to the delivery on the Trubin version 4.1 with the hyperside. So comparing to the Trubin version 2.7, this is the latest version of Varian Linac, and with the high performance, the Conbeam CT. It has a larger KB imager, and it has a gantry rotation is faster, 1.5 RPM. And then the Conbeam CT, the reprocessing is improved to reduce the scatter and also reduce the metal artifact. It has the functionality of the extended field of view up to 70 cm, and also Hans field unit is calibrated. So it has a potential to direct those calculation. These slides basically show the summary that I just told you. And then I just want to show you the example of a case study. This patient has a retroperitoneal the lymph node. So this is a Conbeam CT for the TrueBeam, older version of TrueBeam without the hyperside. And this is with the hyperside. And this is a planning CT. So what happened is we set up the patient, we did a Conbeam CT, and the physician looked at the area and then had a suspicion the tumor might have grown. We moved the patient to the hyperside, and then did the hyperside Conbeam CT, and then it gave the physician assurance that tumor has grown. So we kind of paused the treatment on that day. Patient went through the re-CT, and then we plan, and then we treat the patient. And also, as you can see, with the hypersite, the tumor, the shape is a very kind of similar to what you can see from the planning CT. I wanted to show you this slide. I heard this talk during this year's AAPM, and also this work is published during the pandemic, and then this is about using shallow the breathing, and then it's contactless the motion management. So basically you use a metronome. Metronome is equipment that when we learn the piano, it gives you the beat per minute, tick tock beats per minute. So basically, while you simulate the patient, you play it, and the patient kind of breathing. Basically, like the 60 BPM means 30 breathing rate. So patient is a little bit faster breathing, but shallow breathing. And then they found out that that shallow breathing, that the motion, tumor motion, was able to reduce by 5 millimeter. For example, 14.6 to 9.3 by using that equipment. So this is the result. This is just illustration. So when they use a free breathing, sometimes the patient's breathing is unpredictable, and the ITB is larger. But by using metronome, they said that we can even using the YouTube, and then type the BPM 60, and then by the sound the patient follow. And then this is illustration, but they were able to reduce the size of ITV and the motion of the lesion. I wanted to share with you, even though this is not the APM recommendation or not what we're currently using, but I think something we all can think about, the easier way of doing the motion management. This is my take-home message. I can entertain any question you have. Thank you so much.
Thank you so much, Jan. Great presentation, and thank you for mentioning that paper. We just invited the first author, James Song, to give a presentation at the OncoHub conference in Ukraine. To talk about this motion management technique that's very cost effective. And I think it would be great if it can be used in Ukraine and people can try it there. So thank you for mentioning that.
Great,
awesome.
Great progress. Thank you.
Yeah, thank you. Thank you both for your great presentation. I am opening the floor for questions. So if anyone has questions, please either type in the chat or you can turn on the mic and camera and ask the question. In the meantime, while people are preparing, I was wondering, Dr. Tang, if you are still there. Yes. So you were saying that you are doing the whole genome sequencing of the cancer. How expensive is this process, and do you do this for every patient?
Yeah, so it's not standard of care yet. It's not
Right.
FDA approval. So
Okay.
that was the first time that assay was ever used in a clinical data set. So there's not a pricing behind it yet. But the whole genome sequencing is a lot cheaper, but it's probably not that cheap yet. And you have to do whole genome sequencing of the tumor. You have to do whole genome sequencing of the blood to get your germline controls and subtract it out from the tumor. And then you develop a panel for each individual patient of 1,000, 2,000 different somatic alterations from that.
Yeah,
so it's a lot of sequencing you
complex.
can see.
Yeah.
Yeah.
But that's
But
incredible
hopefully in the future it will,
information, right? So that's an incredible information. So you're doing it on some select patients or patients on trial or registry, or how do you do this?
Yeah, we did it all in the patients on trial that we could get tumor tissue from, and we have a new lab protocol, and our newest trial, Astrials, will do that again as well. but I think you'll see more of this in kidney cancer and others, and we're already seeing it in solid tumors like colorectal and bladder cancer. So we'll see. That's going to guide us just like PSA guides us in prostate cancer.
Oh, excellent. Yeah, that's really exciting. And that's thank you for your great talk and showing all your incredible work on so many trials that you're working on. That's incredible. Thank you. That's very inspiring to see. And I like how you started with the history of radiation is not really appropriate for kidney cancer, and then now such great results. So it's really thank you for your great work on this. And what's your prediction? What's the future, you think? Where are we going next? So obviously we're going to wait for these trials to come successful, right? But then what's next?
Yeah, it's a good question. It's a little hard to figure out where we're going when we don't have like pharmaceutical companies sponsoring our trials. It's so hard to do these trials.
That's
if
a
you
difficulty.
look at the doublets, they do hundreds of millions of dollars on each of those trials. But a future that would make sense to me is one where we start off with systemic therapy, we get their ctDNA or biomarkers to a low state, consolidate with radiation, observe for years. When it goes picked back up, we do it again with systemic therapy and local therapy to make it more of a chronic kind of, we treat the flares of the disease instead of just having the patient on Nivo-IP or Nivo-Cabo or something they're on it forever. They never stop it, right?
Mm-hmm. And I just want to ask a question about also something related to Ukraine. Many of the centers do not have motion management capability, and maybe Metronome would help them, right? But let's say without even a 4D CT, how would you do this in your clinic, Dr. Tang or Dr. Han? Without 4D CT.
Yeah, want to try answer that question?
Yes, without 4D CT,
right?
I think not using any kind of equipment, I would I would ask a patient to shallow breath. That's one thing I can think of. Otherwise, you need to just use a lot of margin.
Yeah, I mean, you can use a compression belt too, and try to minimize that. We've always seen reduction. There's only really, we can tell based where the lesion is located, if it's the left side superior is going to have the most motion, right up against the diaphragm. And you get the stomach has the motion. Inferior lesions, the kidney is a dampener, especially on the right side. The liver is a dampener of the motion too. You have a lot less motion. I'm curious if there's a way to kind of just capture that motion without a 4D CT to give you a sense of what kind of margins you will use. Otherwise, you end up doing a pretty big margin, maybe like a centimeter, because they sometimes remove easily a centimeter for the IGTV.
So compression belt might be a solution for them.
Yeah,
maybe.
We've seen pretty much 9 out of 10 patients, their motions reduced by a couple millimeters to maybe even a centimeter with a compression belt.
Right.
Paradoxically, we've had 1 or 2 patients out of like 20 or 30 who've had an increase in the motion, but 9 out of 10 have a decrease in motion.
Okay, thank you. So I see Dr. Shabil wants to ask the question. Dr. Shabil.
Thank you very much for very interesting lectures. In our clinic, we have a couple problems. First problem, we have a lot of surgery who try operated the kidney. Unfortunately, this is very difficult to change the situation. And we believe maybe your lectures also help for us move this for right direction. Because you show a very great result of the 5 years of overall survival. And I want to ask about compression belt, because in last Astro, if I right remember, we have a lot discussion about what more use the compression belt or help them of the control of motion of organs or not. You have some specific recommendation how use this compression belt, how the pressure must be, and something more practical if it's possible.
Okay. Okay, I'll try to handle the first question, dealing with surgeons, and then maybe, Jan, you can do the second question about compression belt. I think dealing with surgeons is something we've done within every site, right? It's thoracic
Yeah,
surgeons
that's
for
right.
lung cancer, prostate surgeons for prostate cancer, on and on. It's not new. I think where we saw more patients is when the surgeons were overwhelmed. So we would get the really, maybe the larger patient would they knew it would take many hours, big surgery, where the patients with the calculi in the single kidney. So that's where we can, and those aren't too hard for us, whether doesn't matter if they're large patient or small. So what we've been finding is when the surgeons are overstressed, we start getting more of these borderline cases, and we're happy to do them. And that's what we've done with the longest time. And once the surgeons see good results, then they're willing to send maybe a little less borderline. And that's just how radiation works, I think, in this area. Jan, any thoughts about the compression belt?
Yes. Can you hear me okay?
Yeah.
Yeah, compression belt, the thing is, we need to analyze the motion before and after compression belts. That's, I think, one of the most important aspect, because sometimes the compression belt either doesn't work or increase the motion. And that's why that we want to do quick scan without the compression belt and with compression belt, and see how much motion is really act. And then I believe for the lung, upper lesion, and then medial lesion, the compression belt is not very impact. But I think for the kidney SBRT, a lot of the time we observe the compression belt to help if a patient cannot deal with the breath hold.
Okay, thank you very much. And about metronome, one more question. You teach patient how they need breathing for the metronome. Yes, I right understand this.
You mean the metronome case that I show you?
Yes.
Oh yeah.
Yeah.
So the thing is, that one I heard during the APM, so I wanted to share with that idea. Do we haven't implement but metronome, I think you can buy in the $5, and then but the thing is, I want to make sure this is a good idea, but it's very important the physicist to thoroughly investigate that it's safe to use. So, but the metronome itself is very cheap, and you can even use YouTube. Basically, you ask a patient to follow the breathing. So usually they use the 50 to 60 beats per minute, which is 25 to 30 the breathing rate. And then a lot of patient was able to comply with it.
Follow,
Yeah, I think that's a very, because the compression belt, some patient is uncomfort and cannot do it, and then sometimes no effect. But I think this, if we can calibrate carefully and make sure the patient's safety, and then also dosimetrically kind of the study, after that, I think it may be more impactful than using the compression belt. That's my personal opinion.
Oh, that's great. And we'll hear more about metronome, I hope, at OncoHub. I think that Jason agreed to give a talk, so that's great. And
Yeah, that's great. And then
Yeah.
even ask him that I was thinking of even asking to have some project. If a couple of site want to move on
Yeah.
with the metronome project, and then
Yeah.
maybe he can provide the guidance through it,
Right.
during
Teach
the
how to do it.
commission it, commission it, and you guys can publish the paper. And also,
That would be awesome.
yeah. And then I also let me know if I can help. Yeah.
Oh, that's awesome. Thank you so much. Yeah.
Thank you very much.
Thank you, Dr. Shepard, for asking a question. And Dr. Bruvchuk, do you want to ask a question?
Yes, thank you very much. I want to express gratitude to both lecturers for very interesting presentations. But partially you have been replying to the using of compression belt. I wanted to find out how much it can reduce the motion, but I think it depends really on case, and actually we have to test it. The other question is that there is an existing article about breast hold, which is like a very hands-on breast hold with just a camera in a bunker, where when you put a mark on a patient's body to monitor that he breasts holding his breath, and you simply monitor that and stop beaming on manually when you see that he would like to breathe on. What do you think? This might work, I think, for, like, let's say treating for conventional fragmentation, like treating breast cancer. But would that something like that work, or would that be dangerous to use it for SBRT?
You mean not the Varian RPM system? You mean the
manually?
Yeah,
so they want to control manually. Turn on the beam, turn off the beam.
Oh, I see. I'm not sure. Yeah, but again, the I mean, if there is, I think it has to be carefully calibrated.
Yeah, I think it's okay to do for conventional fractionation for breast treatment, for example. You can manually turn on, turn off when the patient, but you have to watch the treatment very carefully. So you have to really rely on your therapist to turn off the beam when patient is, bleeding out, right? But for SBRT, it's not appropriate because it's too high of a dose per fraction.
And as I show you in the take-home message, whatever we did stimulate the patient and a plan, it has to be consistent with the treatment. So when we test it, we think about the end-to-end test. If we use the phantom, breathing phantom, and then it has to be from the patient consultation to patient delivery. So we need to kind of incorporate simulation stage to not just delivery.
Yeah, thank you. I agree. Thank you very much.
Thank you so much. And the team prepared for you the homework. So I'll show you the homework. Share the screen. So this is the case, a kidney case. Do you want to talk a little bit about this? Or maybe we'll send more follow-up information for planning.
I think that Dr. I will follow up with this one.
Okay, sounds good. So I will send the follow-up information about the case and how to plan this case. But this is challenging. This is something that Dr. Han showed you, where you have a differential dose areas of the target that either in close proximity overlap with bowel or away from the bowel, right? So it's a challenging case, but it's a very good case to practice. So this case, it looks like it was done with static MRT.
Yeah, so that's what we use for the all CTOR case.
Okay, sounds good. But the majority of your cases now are MR guided, or you're doing
about half.
Half, okay.
Well, half the time we can't do MR guidance for the patients to claustrophobic or
right.
cardiac pacemaker or this, that, the other. Yeah.
But you try to mostly do them MR guided, and you also do adaptive?
The adaptive less so, depends on where the location is. Online adaptation can be a little bit onerous. The patient's arm gets very tired from holding up for that long.
Right.
But if we need to, we will. But we put a PRV on to allow for a little bit of wiggle room for the bowel. But we had to look at it case by case.
Okay. Sounds great. Thank you so much again for giving a great lecture. That was excellent. And for everyone, we'll have our last lecture in the series next week. So see you next week then. Bye-bye. Thank you.